healthcare is one of those areas that's got great societal need. It's an area where technology has had early on some really big impact, but a lot of items to be proven here. We've got Jim Jusko, who is going to be our moderator. Jim has been a friend of the Easton Center. He's been a friend of our Innovation Challenge. He is a professor at UCLA. He's got a lot of deep expertise in healthcare and in communications. He led in 2019 a UCLA Health Innovation Challenge Award project that was focused on the clinical value of patient stories and how developing technology can bring really unprecedented changes to healthcare, primarily through transparency. So Jim, a big welcome to you, and I will turn it over to you from here.
Sounds good, Terry. Thank you very much for that kind introduction. And I am thrilled to be able to get underway and introduce a really terrific panel and a conversation that we have. So without any more small talk, let me provide a quick introduction and we'll get right into it. We have with us on our panel 3 fantastic, amazing innovators who've had a wealth of experience in different areas of healthcare. So I'll introduce briefly Ritesh Patel, who is the Chief Digital Officer for Health at Ogilvy Consulting and works with large clients on digital transformation and innovation. He brings 20 years of digital experience to his passion for creating what the future of digital healthcare will be. James DeConer is the Director of International Health here at Children's Hospital Los Angeles. He's both a doctor and an entrepreneur and co-founded Orderly Health, a venture-backed digital health company. He's also currently working as a clinician advisor for KidsX, a pediatric digital health accelerator. And Ted Schwab is with us and is a strategist, entrepreneur, and digital experience expert. He spent 20 years leading healthcare strategy divisions of major consulting firms, and most recently led the introduction into the United States of Babylon Health, an AI-backed digital primary health platform. And he is also an Anderson School alumni. So welcome to all of you. Thanks again for joining us for this conversation.
Thank you.
All right, so let's dive in indeed. It would be terrific as a way to get to know each of you a little bit personally and professionally. I would love to just have each of you respond to sharing with us what project as part of your work has been most meaningful to you personally.
So I can go first if that works.
Yeah.
So for my current projects, one of the things I think is most meaningful and interesting is working with the school system to develop kind of care-based delivery models that address children's needs at school without taking them out. So one interesting finding from LAUSD in that work is the #1 reason a kid misses a day of school is a medical appointment. Each day that you miss school, the state reduces the money to LAUSD and the child gets further behind. And so if you can come up with new care delivery models, there's a lot of opportunity there to improve education.
For me, I would say making medicine affordable in Asia. So worked on a project where in one market, this was Malaysia and Indonesia, folks can't afford basic vaccines in some cases. And what they do is they get the family together, everybody pulls their money together for somebody to go get vaccinated, and then each other pays each other off. So it's a sort of a sub mini banking system among friends and families. And so what we did was we did a partnership with Gojek, which is the Uber of Indonesia, to use their e-wallet technology, where now you don't go to friends and family, you get 24 months interest-free credit to pay for your vaccine and then pay it off on the e-wallet of Gojek, which is something you're using on a daily basis. And AXA, we brought in AXA as the underwriter for it, so that Gojek knows your credit, they know how you pay, they know what you're worth, you're doing all your shopping through them, and now you can get vaccinations through them. So making it affordable for people to get vaccinated.
Yeah, Jim, sort of like James, my mind goes to some of the things I'm working on today. And one of those is transforming the largest behavioral health company in the United States into a digital behavioral health company. And so that's taking it from human to human contact to human to machine contact to digital prescribing, in concert, working with major academic medical centers. It's developing digital therapeutics. And if you think of supply and demand in behavioral health, just any way you cut it, there's not enough supply. There's never going to be enough supply. And so this takes it for emergency acute medicine, which is really what psychiatry has become these days, into a service for the masses. So it's really exciting.
Wow, terrific. Yeah, thank you very much. So we'll probably return to a question of behavioral health before long because it's connected to such big issues in the US. But first, I was thinking we would start maybe at that 40,000 foot level, but I realize that's not big enough. There are global challenges and opportunities, and some Wikipedia page said you had to be 600 miles up to see the Earth as an entire globe. But taking that view, and all of you have had activities that have brought you into international things from Asia to Africa and elsewhere, I'd love to get your opinions about when a technology company involved in healthcare goes to do something internationally. Is it because it is really profitable and a good part of a business plan? Or is it more of a proving ground to test an experiment on some other people before you bring it into the US? Or is it really that you can do a lot of good for a lot of people at scale? Where do you come out on that kind of thing?
I'm going to go first because you've got a major assumption in there that I would like to challenge, is that that technology in the United States is leading the way in healthcare, and that it is us who's going to go international. So I'm working and setting up a venture fund in the Midwest that is focused entirely from bringing technologies from quote unquote overseas into the United States and then scaling them here in the United States. And I would make the argument that artificial intelligence coming out of the Middle East is far beyond what I'm seeing coming out of the Silicon Valley. That some of the protocol-driven, machine-backed healthcare coming out of Africa is stunning compared to what I see coming out of Boston. And some of the stuff coming out of Asia in the gamification of healthcare is great advances. So, I do want us to get beyond that prejudice. I know I have had for a long period of time that the United States is leading in healthcare technology. Not to say that great things aren't happening, but I think there are great things happening internationally too.
I think, Ted, the nuance there is a lot of technology that's being developed, but I think sometimes markets also dictate some of that.
Absolutely.
Right?
You're absolutely right.
If you look at what Ali did in Babylon in the UK, it was fantastic, but the only way that business can really now grow is to bring it over here, for example, and make it, because the demand is higher here. Plus, I think there's a bigger opportunity to do some of those things. There's a huge number of startups. You see record funding going on right now in Silicon Valley for startups. I work with a lot of physicians who are leaving practice to go do a startup because they believe, if I'm going to pull my hair out 18 hours a day, I'm going to do it on my terms for benefit for me, not, the system I'm in. But I think you're right. I think the big misnomer everywhere is that it's the cornerstone of Silicon Valley. It really isn't even Valley. Louisville, Kentucky, Nashville, Tennessee, you got Portland, Oregon, some amazing stuff. Boston, Massachusetts, amazing stuff coming through. And then the usual suspects, Tel Aviv. I've done a lot of work in Ghana and Sierra Leone where they're doing crazy stuff with mobile. Blow your mind. So I think it's a market thing as well.
Yeah, and then kind of one other addition. I come at it from a different perspective, working in low and middle income countries primarily. And so one is, I think, really what defines technology is the business model around it. And so there's certainly technologies, companies, examples we can point to that are extractive in the sense that they're pulling money out of those areas. But there's also ones that are very additive to the healthcare system. And so when I think about technology, particularly overseas in the places that I work, I think about leapfrog development. So, working in a country like Armenia that, really doesn't have a standard electronic medical record system, every hospital still uses paper. There's a real opportunity there to leapfrog what we have in the US and maybe even in Western Europe, which I'm not as familiar with, and create something that's truly patient-centered, truly transportable, something that's mobile. And so when I think about technology in that sense, I think it can be really additive. And you can look at, there's a term called third world prototyping that I don't like, the implications of it. But there's an opportunity to develop the technology in a place that doesn't have any incumbents, that then would have value in a place like the US.
Yeah, there's a number of
Very
companies that
well.
I'm working with that are building things for Africa, for Pakistan. There's an EMR, an Android-based handheld EMR system that's been built specifically for India, because you need, that kind of mobility, but it has to be low cost as well.
Yeah.
So you're absolutely right, James.
James, and that's also happening in the United States, going into disadvantaged communities with new technologies. So, for example, I've worked with the country's second largest nonprofit healthcare system in building a quote unquote digital healthcare plan throughout the South. And their economics are, as even if somebody is a Medicaid beneficiary, they're at risk. Because every time a Medicaid beneficiary comes into their facilities or their offices, they lose money. Yep. And so they're trying to figure out how to deliver digital services to that community that are on par with physical services. So you don't have to go overseas to try to find low-cost ways to bring technology to disadvantaged communities.
Yeah, no.
Yeah, no, very, very interesting. Hey, I'd love to ask you about the kind of the kind of companies, the entities that you see maybe being best positioned to sort of take on these challenges. Maybe with this kind of a backdrop that, certainly we've seen big companies that are entrenched healthcare players with a lot of money, payers, pharma, doing all sorts of things, making investments in companies, great and small. And then we have big companies outside of healthcare, Google, Amazon, or some others that could be big players, but they are not, no legacy experience in it, which could be a plus or minus. Or maybe none of them matter. Maybe it's smaller, innovative companies that come out of nowhere and just out-innovate everyone else. Since you were involved in that entrepreneurial side, James, I'd love for your comments to maybe start off, but all of you would be great to weigh in.
Yeah, I mean, I am a little bit out of shape, I guess, when it comes to, kind of the venture landscape, looking at startups. But there is, that interesting trend, right, of these tech companies that are trying to get into healthcare, and historically they've done very poorly. And so it'll be interesting to see what business model Amazon can put together and if it's successful and they can reach scale. I think Walmart's a fascinating example with their inroads, just because they have that tie to the more rural community, which is so underserved. I think there's a lot of opportunities there. But yeah, I don't have any this is the golden company that I really respect right now in healthcare, at least in the US side.
I would also add to that the pharmacy companies, CVS and Walgreens particularly, who are doing some really interesting things. Walgreens, I've seen really amp up their innovation side, and they're looking at new ways of getting things to you, looking at new ways of getting you to them, that sort of stuff. Some of it is out of necessity, obviously, because of the pandemic, but other things like the agreement between Walgreens and Postmates in urban areas to get your prescription drugs delivered to you, right? From an innovation perspective, I do a lot of work with the small startups or the emerging startups as they're coming through, with innovation funds that are being put together, or innovation centers that are being put together by the health systems. So, Banner's got one, they call it BIG, Houston Methodist has one, Sibley's got one, Thomas Jefferson's got one, et cetera, et cetera. And Mount Sinai has the innovation partners thing. So I think there's that combination that everybody's trying to sort of figure out where they fit in. The big innovations are coming from some of those smaller players who are looking at one use case or a niche, and it's mainly a physician who's leaving practice to do that, right? And saying, I can fix this, and there's a technology, and they're digitally savvy, they can't do it in the system they're in, so they'll go out and do it. And so some of those things, I talked to chap last week who's created, now there seems to be an arms race going on with these online pharmacies. Capsule said you'll have it within 2 days. Then, I think now RX says you can have it in 5 hours. Well, this guy's going to deliver your prescriptions to you in 2 hours, guaranteed. Not sure whether that's a good benefit or not, but they're building businesses like that, which forces the bigger incumbents to either change their model or look at doing something in partnership or in collaboration, I think.
Yeah, I think there are 3 companies that right now are going to change American healthcare. The first one is Teladoc. And, 8 years ago, they were a $40 million market cap. Now they're somewhere between a $40 and $60 billion market cap. What they're doing in trying to capture the consumer, the direct-to-consumer market, the institutional market, and now the at-home chronic care market is right on target from a strategic perspective. We'll see if they can operationalize that.
That's the issue.
The second one is Amazon, and not so much from Amazon Health, but from Alexa. And I've seen some of the demos, some of the therapeutic demos of what Alexa can do. There's a long way to go to get it through the FDA, but you think of alerts, you think of notifications, you think of digital therapeutics, you add the video to that, and you begin to get retinal diagnosis, you get to get tonal diagnosis, facial expression. And then the last one, I think, is LexisNexis. And I was having this conversation with somebody just yesterday, and they said, if Walmart could combine with LexisNexis, that would be the healthcare juggernaut, because LexisNexis knows everything about you. And Walmart has that retail experience. And I was talking with an executive from Walmart and said, look, if the federal government came to us and said, help our customers lose weight, we would do that because we know how to do that. We know everything about them. We know their buying patterns. We know their living patterns. We know what they consume. And if it's a lifestyle change you want, we can help you do that.
Wow.
On mute. The only thing on that one is they're feeding the people who are getting obese in the first place. So there may be a profit hit somewhere along that conversation, right?
But his point, you make his point exactly, is look, our incentive is to sell stuff. So we sell stuff.
Yeah, that's true. That's true.
Change lifestyles, we'll change lifestyles. It's about incentives.
Exactly.
Well,
on your Alexa thing, Houston Methodist has got an Alexa in every room now. And they've seen the delivery of care and their NPS scores go through the roof because of it. Because now you don't press a button and a nurse arrives to say what's wrong. You tell Alexa, hey, I want my food. Nurse gets that message. He or she doesn't go to see the patient. She just says, hey, go get food. I don't need to go visit the patient. And I was talking to Roberta Schwartz yesterday or 2 days ago. And she said that innovation in every room has completely changed the delivery of care for patients.
Yeah,
Isn't it amazing how simple innovations like having somebody or something to talk to changes healthcare?
Completely, right?
So I like simplicity.
Yeah.
I think one final addition is the hospital systems and the providers really becoming engaged in innovation, right?
Absolutely.
So I'm part of KidsX, which is kind of run through CHLA, which is a pediatric digital health accelerator. But we were trying to get, I think, 10 hospitals to sign up, pediatric standalone hospitals, and we're at over 35. The demand's far outstripped, and that's during a pandemic when pediatric hospitals are being crushed financially. There's that much latent demand to be able to tap into innovation and just see what's coming. And so I think that's a really interesting change that, at least when I was running my startup, did not seem like it was happening. And there's a lot less interest or buy-in.
Yeah, very well. Well, focusing a little bit, taking a little deeper dive into the areas of disruptive innovation that might or might not be out there. Let's observe this, and I'd love to ask you all a question. Certainly, if you drive a truck or bus or a cab, you could be very worried about the future of your job given the advances in driverless technology. If you work in a small hotel motel, you're worried about Airbnb, which might put you out of business. And if you're in manufacturing, 3D printing and robotics threaten you. We could go on and on. But then we look at healthcare, no one I know in healthcare seems to be worried about losing their job, which is this really a good thing in the view of what disruptive innovation can do to tear down prices and make a system that's more cost effective and manageable? What do you think?
Look, the difference here is, there are people who could die if you do it wrong, right? The disruptions are coming out slow. And I think part of it is the inertia of the health system itself and the complex nature of it that has been defined by the health systems and the providers of health, whether it's you pay for it or you consume it or whatever it is. And so what you're seeing is smaller disruptions as opposed to a big, massive shift that some areas of industry are going through. So what I see is these innovations around delivery of care, like the Alexas in the rooms, like handheld ultrasounds, as opposed to the big, $75,000 machine that's in the basement with 2 trained nurses who have to operate it. Things like that. The handheld stethoscope, the at-home kits, the AliveCore EKG. You got a 6-lead EKG for $189 that you can give to every AFib sufferer or anybody with a heart event, right? That can then be monitored remotely. So I think it's those point things. If somebody can then bring them together, like your point, Ted, around LexisNexis and Walmart, or James with a group of hospitals getting together and really push for it, then it will happen. The other piece of this is policy and regulatory hasn't caught up. I know Bakul Patel has put together this digital thing at the FDA, but they still have a little way to go. So even if you do a massive innovation, getting it through the policy and regulatory process and actually delivering on it takes a bit of time to do, because you have to prove a lot of things. And those are all the things that I sort of wrestle with, to your point around why hasn't this happened as fast enough in the healthcare industry. I'm going to turn it over to my learned colleagues who know more than I do.
James, go ahead.
Yeah, sure. Building on that, I think you're right. Part of it is people aren't scared of losing their jobs because healthcare moves so slowly. It's a lot easier to outrun the glacier than it is, a Ferrari. And so that's part of it. But I also think that there's a little bit of complacency, at least on the provider side, in the terms of, well, it's always moved slow, so it's always going to move slow. And I don't think that's necessarily true. So healthcare is a complex adaptive system, right? It wants to stay in stasis. And most innovations are individual actors, so adding an Alexa to a room, they might change a little bit of the patient experience, but they're not trying to upset the whole entire system. And I don't think any individual actor, company, organization can completely disrupt it. But I think we're on the precipice of seeing healthcare radically kind of get blown apart. I don't know exactly what the force is. It's going to be a number of forces. And then it's going to reconfigure in some way that I'm not smart enough to imagine. But when that's happening, and we may be in that moment, there's a lot of opportunity for innovation and to make system level changes. And so to try to pull together all of those pieces and redefine a care delivery model that has a financial model that supports it, I think that moment may be now. And if it's not now, I'm betting it's going to happen in the next 5 years.
So, Jim, I think there are some people who are afraid of losing their jobs and have already lost their jobs. One, it's office workers in healthcare. I talked to health system after health system, health plan after health plan, and they're letting their leases go in office buildings. And just like almost every other industry going to remote work, healthcare, they're not coming back until June of 2020 in the major healthcare systems in the United States. So people who work in office buildings and people who support office buildings are very, very scared. The second thing is the medical office building industry. What we found during the pandemic. So for example, I also work with Mount Sinai, and they went from about 3% of their office-based care being delivered through telehealth to 85% in a week. In a week that happened. And so what they found is that they had the infrastructure in place, the doctors kind of dug it, and consumers loved it. That's not coming back. There's estimates that the telehealth space will kind of find buoyancy around 25, 30%. I think it might be higher than that. But what we thought of as the medical office building industry, I think has a big hole shot in it. And my last thought about this is that it all relies on the home and what we can do with people with sensors, with Internet of the Things, and with communication. And the example that our colleague just gave around home EKGs, that stuff is spot on. It's efficacious. It works. A friend of mine is now leading a company with a mobile MRI. And 10 years from now, they're talking about how do they get that onto a car and start doing MRIs in people's homes. So I think there are some people scared.
I think if you're a GP or a PCP, you should be scared, because that piece of delivery of care, the routine and the remote, that's going to disappear for sure. The pandemic is going to force you, because you're right. I talk to doctors. I do a lot of work in rural America because the hospital shutdowns are happening there. And, in some cases, economies are devastated because not only is the hospital, but it's also the largest employer in that town. So how are we going to sort of shift the model? And that whole telemedicine combination of connected devices with telehealth is really providing that capability to remote patient management. And if I'm a GP or a PCP, I should really be looking at how am I going to be part of that ecosystem, because it's not in the building anymore.
You're right.
Yeah, my question for both of you, though, is you've talked about the loss of the physical office, which I agree with. But does that negate the role of the human, the provider in that case? So whether I provide it sitting in my office here, telehealth, or I do it from my bedroom, do you see that the need for, the nurse practitioner, the PCP, the primary care doc going away in this future, in the next 20 years?
Not going away, but a different model. Give you the example of Ping An in China, that is putting remote booths. These big red booths are being put into remote villages in China. One side is all the drugs. So when you get the prescription, you literally get it dispensed. like a packet of chips from a machine. It drops down, you take it home with you. But the other piece is you sit down, it takes your weight, takes your blood pressure. The doctors are in a call center in Bangkok. Yeah. They're not even in the country, right? So this call center model is being deployed. So I think it's a different model. It may not be the same model, but you'll always need sometime a human intervention of some sort, until, if Ali gets his way and Babylon becomes intelligent, or Ada becomes intelligent, some of the machines can take over some of those routine things. I've seen one very interesting one, a diabetes AI app that is very, very good at predicting sugar levels after you eat something. So when those kinds of things start appearing, then yes, I think the PCP GP will definitely go away.
Interesting.
Yeah, I wouldn't say that the PCP GP is going to go away just because of supply and demand. And there's just so little supply worldwide and in the United States. And the demand for healthcare is almost infinite. But what I do think James will see is machine-assisted primary care at the diagnostic phase. The stuff coming out of Google with retinal diagnosis is, kind of stunning stuff. The pathway developed stuff with Ada, Buoy, Babylon, and others is getting better, and it'll get better over time. So
radiologists. I think radiologists may be one, Ted, because look, imaging, Philips is embedding Zebra technologies into the MRI now. So you don't need a radiologist to read the x-ray. The machine does it. Right?
Well, an x-ray or AI is better at reading a chest x-ray now than a radiologist anyway. Same thing with an EKG, right?
Exactly.
And so my view of it, I think aligns with both of you guys, but particularly Ted's, is there's going to be a shift towards whoever the provider is, whether it's a physician or not, focusing on kind of additive, and the diagnostic phase is just going to be overseeing whatever the AI is. There's no reason for anybody other than a very, very specialized electrophysiologist to be reading an EKG today, right? Same thing with the chest x-ray. And, it's probably true for a CT scan, but as that goes forward, you're going to see, some of these special niche specialties like radiology having to switch. And that's why, most of my classmates that are in radiology are now doing interventional radiology. And you're going to see that trend continue.
Yeah.
Hey, so I think it'd be great to, before we'll be going to some Q&A audience questions pretty soon, but let's step back for a minute and give ourselves a chance to leave behind all of the cool lingo that centers around digital health. And that is all these great, amazing opportunities. And we've talked about who are the companies and players that might come in for diagnostics and therapeutics and care delivery and, and data analysis and all this amazing stuff. And I'd love to ask each of you if you think there's an area that is being missed, something that might be neglected, not cool, not sexy, but could impact the healthcare for Americans in a big way. And we could be anywhere. We could be in the realm of, how commercial health insurance is bought and sold, how community health workers function, how retail pharmacies operate, home health care, the things that leave behind the whiz bang of the Googles and Amazons of the world. What's being missed out there? What advice would you give to an entrepreneur looking 10 years out and guiding their career that there might be something great that no one is noticing and they should put their mind to?
Can I go first?
Yeah.
Changing computer programmer bias. I think that's the greatest threat to American healthcare. I presented at the Amazon conference in Vegas the last time it was open. It was my first time there. I was shocked. Probably 98% male, 75% Caucasian. The rest of the 25% was Asian. And I looked at presentation after presentation, and they all had this representation of a patient, and the patient looked like me. Most patients in the United States of America do not look like me. And so we all bring our own context to fixing healthcare. It scares the daylights out of me that Caucasians, Asian males are designing the next generation of healthcare. And if we can fix that, I think it'd be terrific.
I would absolutely violently agree with you, Ted, and then I would add to that the underserved. We've got such disparity. My work is very much with underserved entrepreneurs and underserved patients. You look at parts of this country, and I grew up in Kenya, and then I grew up in London. And London, we took the NHS for granted. Everybody had equal access, even though services may be a little different. The disparity is growing dramatically here, particularly as digitization takes off. That there are, even in Mount Sinai, they serve the poorest population up on the Upper West Side, and they serve the richest population on the Upper East Side. You look at the care delivery and the kinds of things we need to do. I think there's a huge pent-up demand, and if you're an entrepreneur of female African American, your chances of getting funding, getting going are increasingly difficult. So how do we fix that? If we can fix that, and there's a couple of funds that are now starting to do that, right. I think there's a huge opportunity.
Yeah, and just adding to that, I don't know what the percentage is, but social determinants of health control so much of outcomes. It doesn't matter how great your MRI machine is. If you're not addressing, the stuff that's happening at the block level, right, in the household, you're not going to change outcomes. And that's the goal, right, is to change outcomes here. And so, I look at entrepreneurs, and there's very few that I've seen that are really trying to dig into that. And almost everyone that I know that is doing that work is somebody that's a person that came from that neighborhood, right? Typically a person of color. I don't know what the ratio is, but at least 50-50 male to female. And it's because they have that personal connection to that problem. And so figuring out how to put innovators, both with venture-backed models, also in research. There's other ways to innovate outside of venture capital, but getting those people in a place where they can succeed and be supported is incredibly important. And if you want to talk about, raising the standard for the bottom 50%, you're going to do it through social determinants of health.
Yeah. You look at someone like Ivelisse, who's, doing this work with Radical Health up in the Bronx. She grew up in that area, and she got a startup going, and she's got some good partnerships now with some of the hospitals, because, that's the only way she could get going up there. But she's doing some amazing work at the community level. So
Yeah, so well, let's pick up on that thread a minute, because also you're already tackling some questions that have come in on Slido here from the general audience and participants here. We've had questions about how technology can play a role in addressing implicit bias of caregivers in care design systems. Ted, thank you for your comment a moment ago, and I'm sure you may expand on that. We've also had a question about what role do we see advances in tech addressing serious health inequalities based on gender, race, and socioeconomic status. This clearly is a very big issue, and if we as a country don't get our head around it, we're going to have a hard time improving healthcare. But this is also a panel here at the Anderson School, and taking a market and business systems look at things is one of the things I'd say we like to do. So for all the need there is and the good works that some of you have just cited and some of you have been doing yourselves in these areas, is there a marketplace or other set of mechanisms that will allow social determinants of health to grow and be addressed at the important levels that it must be addressed at? How do you see that happening?
I think it will, and I think we've seen pieces of it happening. If you look at health systems and what they're trying to do around pricing of products, pricing of services, value-based. You hear, how do I get enough data to give me the opportunity to create a value or a risk-based pricing model? And anybody who can go around looking at that from a market perspective and say, yes, this is the size of the market, this is the amount of patients you're getting through, these are the kinds of things they're going with, and based on that, create models for pricing that will change the cost of care. I think that's a massive opportunity. I think every health system is looking at pricing and outcomes, and how do we manage the two from a market perspective without, because the margins aren't that big, 4 or 5% in some hospitals, which is good. I'm a Patel. I like 50% margin businesses.
Jim, what did Rahm Emanuel say? Never let a good crisis go to waste. Look, folks, we are in the midst of a 100-year black swan event, pandemic.
Yeah.
And the kind of things coming across the table in discussions, I've been in healthcare for 35 years, I have never, ever heard. People are beginning to think differently. And look, the conversation with Walmart, which was tongue-in-cheek, certainly, but that's been since the pandemic, and they've changed their attitude. Some of the things that we see coming out of Amazon and Alexa, it's been since the pandemic. We have formed an entire new industry of digital telehealth within the confines of the pandemic.
In 5 months. In 5 months.
Because it changed the economics. You had all of these doctors who could no longer work in medical office buildings because there was no patients. They found a way.
But don't you think, Ted, that the CMS was also integral in this, in allowing reimbursement and also allowing cross-border, state border practice?
But those regulations had been proposed for
years,
at least a decade. And we found a way to go do it. We had a need, we had a market, and Americans found okay, well, let's change those regulations. And they did it overnight. It was just amazing.
Sorry, James, I cut you off.
No, that's okay. I was just going to add, the pandemic and accelerating. So I work with Innovation Studio at CHLA, and I don't remember the goal. I'm just going to make up numbers here, but the multiples are correct. We had a goal of, say, doing 1,000 telehealth visits for primary care by the end of the year. And within 2 weeks of the pandemic, we were 30x that.
Wow.
An academic center, slow moving. We couldn't get the right people to, commit to meetings. Meetings kept getting rescheduled. A week into the pandemic, we had the executive leadership lined up and moving forward on it. And so that type of change is what I'm talking about, where, the whole system's kind of crumbling and being reassembled right now.
But the thing is, will it stick? So I had this conversation with the CIO of HSS last week. Mm-hmm. And she told me, look, last year we had 219 total telehealth visits, 219. This year, in last month, they had 220,000.
Yeah.
And she said, I got Epic to deploy something in 4 weeks that they always took a year and a half to deploy for me. So the question I asked her was, how much of that will stick? Will you hold Epic to the same standard next time you open another area? And they come back to you and say, oh, well, now the pandemic's over, I need a year to do this and 200,000. Or are you going to hold their feet to the fire and say, you did it last time for 4 weeks, why can't you do it again in 4 weeks, right? How much of that do we think will stick? Because that's part of the market, if you think about it, right?
I think it's just let me finish with one thing, Jim. I think it is a function of the length of the pandemic.
Okay.
And look, if this drags on, I do not want to be an alarmist, but I was talking to a high government official about a big contract yesterday. They've got a 4-year model. It's not a 4-month model. It's a 4-year model. And that's not saying we're all going to be in our homes for 4 years, but by the time they get the vaccine through 360 million people and life gets back to quote unquote normal. So if it was a 6-month black swan, I think things pretty much go back to normal. If this really does stretch out to 36, 48 months, and we've got to find new mobile technologies to take care of folks, I think the longer it goes, the more stickiness we have.
Yeah.
Sorry for interrupting you, Jim.
No, that's okay. My only other additional piece is, clinicians aren't going to go back, right? I work with a number of, primary care pediatricians, and they love the telehealth model. They feel like they're much more efficient. They're delivering better care. They're addressing the patient's needs because they're not in an office. And while physicians often bury their head in the sand when it comes to innovation, typically when they do want to see something change, and they're organized on it, they make it happen.
Right.
So maybe not the best or most efficient innovators, but they can make change. And I think that's not going to go back, even if the pandemic ended tomorrow.
Yeah. Hey, it'd be great to extend on all of this and think about all of us that are present here in this experience, discussing and listening and being part of this, and all of the people we might become in 10 years. When we think about leadership, I guess, there's this unbelievably challenging environment in healthcare. I would describe breakdown of the traditional relationships among payers and providers in pharma, unprecedented pressure on government to meet human needs at a sustainable cost, all in an environment of extreme political tension. I was about to say what kind of qualities do leaders have, but I'd rather internalize it for all of us here. What kind of people and leaders do we all need to become over the next decade to navigate businesses and institutions and lead them through this phenomenal time period from a business perspective? What are we missing? How do we recreate ourselves to do this, to be up to this task?
So a few traits that come to mind. One is just acknowledging healthcare is hard, right? It's hard to work in. It's frustrating. There's way more actors than you ever realize anytime that you start down a venture or building a business model. I think the second thing to recognize is making a small change in healthcare can have a profound impact on people's lives. Maybe it's a small number of people, maybe it's a big number and a small change, but it matters, right? Healthcare really does matter. It's not another dog walking app. It's not something that gets you food a little bit faster. And the third thing I would challenge people as you think about being an entrepreneur is really consider the business model. Really consider how people are equitably participating in it. Is it available to everybody? And then also the efficiency that you're creating, are you just extracting that value and concentrating it within your own company and your own investors? Or is there a mechanism to share that wealth and allow people to participate a little bit more broadly? Each one of those things is really, really hard to do, but it's also incredibly validating and rewarding when you have success because it matters.
If you look at the success some of the entrepreneurs are having, and some are very public unicorns that have occurred, the Livongo folks, etc. But there's a trait that's common, which is passion for that one thing that they're focused on, that the impact it will have on the customer that they're serving in this industry. It's a little different than I'm going to make an app to, get somebody a ride, right? Which has always been used as the standard, let's go be Uber, and it doesn't work that way a little bit. So I think that passion translates very quickly as a leader into an organization that understands the business model, but also the impact it's having on human life at the end of the day.
So when I work with CEOs, I always start with, and they ask this question, you know, the first statement I say is become dumb and become someone else. So then they immediately hang up the phone, but then call me back and go, what in the world do you mean? Number one, by becoming dumb is sort of lift the veil on everything that you thought you knew. Healthcare is so incredibly complex, you know, and people from overseas go, oh, Americans don't know what they're doing because it's so fractionalized. There's a reason for every single regulation. There's a single for every reason that business plans are done this way. And so be open to learning about that stuff. And what I mean by about being somebody else is that we all come to these business models, in my case, with decades of context. Get out of your own context. See things from the consumer's point of view. See things from the payer's point of view. See things from the doctor's point of view. Stop thinking about how you think about it and start thinking about how other people think about it.
Yeah, and I think, Ted, you hit the nail on the head when it comes to that kind of empathy piece. And I have yet to meet an individual that works for an insurance company, a pharma company, a payer, hospital system, what have you, that wants to harm people, right? I mean, some of them may harming people, in my opinion, but that's not their motivation. There's very few evil people, and the person that rejects an insurance claim, they're not doing it out of malice. They're doing it because it's their job, and there's probably a reason for that. And so understanding that reason, both from an economic perspective and also the emotional piece, and then having empathy for that person's position is, I think, a requirement to be successful in healthcare.
Yeah, very well.
You know, I came out of IT 10 years ago. I knew nothing about healthcare. I was running big IT systems at Cushman & Wakefield Real Estate. And it was fascinating to get into this business. And it's taken me 10 years to learn some of the nuances that James was talking about and what Ted's been talking about. But once you get into it and you get that passion for it, it's hard to shake. Because you do, if you make one life, a difference in one life,
that's right.
That is amazing.
Yeah. Well, thanks. That's fantastic comments, especially with a broad audience as we have for this conversation, that there's something to be said for the outsider, the person who doesn't bring the baggage with them into an industry like this and takes a fresh look at things. And, let's see what we have time for. There may be only a couple of minutes left. I probably, maybe taking a good cue from Terry's wonderful technique, I'd love to recap a couple of things you've said, and then maybe just give you each a chance to offer a final thought or two, because we probably are down to our last couple of minutes. But I certainly think it was really fantastic to have it noted that there should never be an assumption that that it's a U.S.-centric model in healthcare innovation around the world. There are great ideas coming from everywhere with unique solutions that work in all different parts of the world. Remembering perhaps from another comment that markets matter, especially in the U.S. as we are configured now, and that we will probably have players of all different sorts, whether they are legacy players, big new tech companies that come from outside healthcare coming in, as well as entrepreneurs. And to James's comment that there may still be a bit of a convulsive moment out there as there is room for this blow apart or destructive, constructive remaking of healthcare. And we know that may happen, who knows, it'll be on the political front, on the front line of primary care and in big tech companies. Ted, thank you for commenting on the idea of programmer's bias, and we could, with other good questions that were asked here from the audience, have spoken a lot more about bias in different areas of healthcare. But those comments are certainly well taken, as are the notion that social determinants of health is really a type of untapped massive need and set of opportunities that really exist outside of our big payer healthcare provider systems, and those are fascinating. And so with that recap, I'm sure I've missed a few things or left out something you might each want to say, but we do have a minute or so for each to offer a final word, and I think then we wrap up. What else would you like to make as a parting comment, if anything?
Three things. Planets are lining up where technology is becoming ubiquitous. We're getting new infrastructures and new capabilities with our phones and our devices and connected things. Two, with that in mind, the market is huge here in the US for the underserved. We have created two-tier system at the moment, and there's a market that's massive. So if you're going to go into being an entrepreneur in the health industry, look at that untapped market of the underserved population, whether it's social determinants or whatever it is. But that market is massive, and not many people are going after that market. And then the third one is, remember, whatever you do, you're impacting a human being. Keep that in the back of your head.
And the thing I would say is, anytime I'm having a struggle with a patient or a family, it's likely the worst day of their month, their year, and maybe their life, right? Or close to it. The work matters, and there's nobility in trying. And so I would encourage, this audience particularly, to seriously consider the intrinsic rewards of working in healthcare and trying to make a real change in the world.
Jim, so Michio Kaku wrote a book, I think he wrote it in 1997, 1999, called Visions, that I read once a year. And he went around the world and he interviewed, I believe it was 125 Nobel Prize winners about what they thought about the next 25, 75, and 125 years. And he has a section in the book on healthcare. And when it came down to it, he said only three things matter. And remember, this was 1997. He described that at some point in time, we will know everything about everybody. He was describing the internet. The second thing is that we will have ubiquitous chips. He was describing sensor technology and the Internet of the Things. And then he said the third thing that matters is the rise of chronic disease. And it's just amazing how somebody in 1997 kind of read the tea leaves, hit the data points, and looked at big things. For our audience, look for big things. We're in a time of big change. The opportunities are big. Do not think small.
Wow. Well, thank you. What fine, fine closing words. So James DeConer, Ritesh Patel, Ted Schwab, thank you all for spending some time with us this morning on behalf of the UCLA Anderson School. We very, very much appreciate you joining us.
Thank you very much.
Again.
Thank you. Take care.